Hi guys, we are moving on to chapter 22, which is going to cover the ankle and foot. So we're going to go over some anatomy to start off with. We're going to break the foot up into three sections. There's the hind foot, the midfoot, and the forefoot. The hind foot is made up of just the calcaneus and the talus, so two bones there. The midfoot is five, the navicular, the cuboid, and the three cuneiforms. And then the forefoot is everything else from there on up. So that's going to be your metatarsals and then your 14 phalanges. So here in the picture, you can see the division. Here we have the talus and the calcaneus here. So this is going to make up the hind foot. As we move forward, the navicular is going to articulate with the talus. Then we have the larger cuboid over here on the lateral side of the foot. And then you have your three cuneiforms. Those are going to make up your midfoot. And then your forefoot are your metatarsals and your phalanges. The major motions of the ankle are going to be dorsiflexion, plantar flexion, inversion, and eversion. And then as we get into the foot, that's where we get into more of a triplanar motion, which occurs at the individual articulations between the hind foot, midfoot, or midfoot and forefoot. Mainly the motions that we're talking about here are going to be pronation and supination of the foot, which I'm not sure if you've gone over too much in depth before, but pronation, we talk about pronated feet. I know we've talked and showed some pictures before in this course, but pronation is actually a combination of several movements together. If you try to pronate your own foot, you will see that when you do that, you will go into a little bit of dorsiflexion, eversion, and abduction of the foot. Supination is then going to be the opposite. If you try to supinate your foot or try to pull up your arches a little bit, you're going to go into a position or a moment of plantar flexion, inversion, and adduction. So I do want you to know that those motions of pronation and supination are not just a single plane. They are made up of each of those three motions. And you can see in this picture here, it shows a little bit better. As you pronate the foot or as the arches start to fall on the foot, that does bring the foot into a little bit of dorsiflexion and eversion. Whereas when you supinate, you are going to go into a bit of plantar flexion and inversion. And those motions, again, are typically occurring at the subtalar joint. So underneath the talus, we're getting, again, a little bit more rotation of the foot there. So the major muscles of the foot and ankle, when we talk, we'll go through by motion. So looking at plantar flexion, that is primarily controlled by your gastroc and soleus complex. They attach to the calcaneus by the Achilles tendon. We also have tibialis posterior that runs on the posterior aspect of the leg. This helps to supinate the foot, inverts the foot, and helps to reverse pronation. So we'll talk a little bit about that one later, but tibialis posterior, as it runs underneath the foot, also helps to support the longitudinal arch of the foot, as does flexor hallucis longus and flexor digitorum longus. Besides supporting the arch, they also will help to flex the toes. On the lateral side of the leg, we have peroneus, longus, and brevis, which are the primary everters of the ankle. I have seen some things lately where some texts and some sources are calling this fibularis longus and brevis, so just be aware of that. I learned them as peroneus, longus, and brevis. I call them your peroneals, so I will continue to do that. These muscles also help to support the arch during weight bearing. And then dorsiflexion, prime mover there is going to be the tibialis anterior, which also does a little bit of inversion as well. And then your extensors, so extensor hallucis longus and extensor digitorum longus, which will also extend the toes. Peroneus tertius can also help with dorsiflexion to some degree. So during gait, the ankle only needs about 35 degrees of motion, about 15 degrees of dorsiflexion, which is within the normal range, and only about 20 degrees of plantar flexion to push off at the end of stance in preparation for swing phase. So that's a total arc of about 35 degrees of motion that's needed at the ankle. When we go through, so we're going to go through the gait cycle and what's happening at the foot and ankle during the phases of gait. So at heel strike, from heel strike to foot flat, as the heel comes in contact with the ground, the foot's going to be in a slight position of supination at this point. Then as it starts to accept more weight onto the foot, it's going to maintain this loose pack position. We talked a little bit about open pack or loose pack positions of the joints. And for the foot, pronation is actually going to be the loose pack position. So at heel strike, again, the foot is in a slightly supinated position, but as we go down into foot flat and loading response, the foot is going to start to pronate a little bit more, which we'll see here on the next slide. So once the foot is then fixed on the ground, the tibia is going to start to move up over top of the foot, right? So heel strike, we're loading, the tibia is moving on top, and it's going to rotate internally, which is then going to put the foot in more of a pronated position. This position of pronation, again, is the loose pack position for the foot, which is going to allow the foot to conform to whatever surface you're standing on. So this is important during foot flat and mid stance because we're basically single limb supporting on that foot. So we want the foot in a loose pack position so that it can conform to the surfaces underneath. And you can see a little bit in this picture how the forces are sort of transmitted through the foot during the gait cycle. We tend to hit more on the outer part of our heel, and then as we load more, we're coming more into the arch, and then eventually we'll push off, and the toe will be the last part of the foot that's in contact with the ground. So then from mid stance into terminal stance, as we're getting ready to swing with that leg, the tibia is going to start to externally rotate on the foot, which is going to put the foot into more of a supinated position. The supinated position is going to be the closed pack position for the foot, which is going to make the foot more rigid. With this rigid lever, that will now help prepare the foot for better push-off and swing phase. So muscle control during gait, as far as the dorsiflexors go and what tibia anterior is going to do during gait, its major roles are going to be during initial foot contact or heel strike, and in that heel strike to foot flat position. The tibia anterior is actually going to eccentrically contract to slow the control of the toes down to the ground. If the dorsiflexors are weak, if tibia anterior is weak, this is where we see foot slap, because the person cannot eccentrically control the toes down to the ground and the toes just hit the ground. The other major job of tibia anterior is during swing phase, to dorsiflex the foot and clear the toes from the ground so that we don't have toe drag. If, again, dorsiflexors are weak for this, a lot of times what we'll see is some sort of circumduction or hip hiking compensation, excessive knee flexion, or that steppage gait in order to make sure that the toes aren't dragging on the ground, because most people recognize when their toes are dragging, and so they'll do something to make up for that so that they don't trip and fall. Plantar flexors are your gastroc and soleus. So at the end of mid stance and the beginning of terminal stance, they control the rate of forward motion of the tibia, and then they're going to function primarily during push-off to plantar flex that foot and get it ready for swing phase. So loss of function here or weakness here will lead to a lag of the lower extremity during terminal stance and little to no push-off then prior to swing. Nerves of the ankle and foot. The common peroneal nerve is a branch of the sciatic nerve. It goes behind the knee and passes between the biceps femoris tendon and the lateral head of the gastroc, and then it comes laterally around the fibular neck and passes through an opening in peroneus longus. So if there is any pressure on this nerve, it'll cause increased symptoms down the leg, usually on the lateral part of the leg and the anterior portion of the leg on the top of the foot. This nerve can be damaged if there is a fracture of the fibula because it is so superficial there, especially again here where it branches around the head of the fibula. A branch of that nerve is then the posterior tibial nerve, which goes behind the medial malleolus along with the three tendons, Tom, Dick, and Harry, and then it's covered with a ligament that forms the tarsal tunnel. So entrapment here can cause tarsal tunnel syndrome. So just like we talked about carpal tunnel at the wrist, there is a very similar condition called tarsal tunnel at the ankle. So it's underneath this ligament, this flexor retinaculum, where the posterior tibial nerve can become entrapped, and then it will have all the same symptoms of carpal tunnel, pain, tingling, numbness, loss of sensation along the bottom of the foot. The plantar and calcaneal nerves are further branches off the posterior tibial nerve. They go under the medial aspect of the foot and up into the arch of the foot. They can become entrapped with excessive pronation. So again, think about the position of the foot and the ankle when the foot is overly pronated. Those arches are falling. They're coming more medially. And so now we're putting more pressure down on these medial nerves. If these nerves would get trapped, again, these are further branches of the posterior tibial nerve. This is known as Baxter's nerve entrapment. So now to move into some of the common conditions that we're going to see at the foot and ankle. Some of the hypomobility conditions, things that would cause decreased mobility at the ankle would be RA, OA or DJD or joint trauma, post-immobilization stiffness, and then we'll talk about gout a little bit here as well. Gout is most commonly seen at the first MTP joint at the great toe, which might not seem like that big of a deal, but we have learned and seen that any condition that affects the great toe is going to have a pretty significant impact on gait. It's going to limit push-off, it's going to alter the whole gait sequence, and make gait painful for the patient. So we'll talk about gout a little bit here. And here are some different pictures of gout. Gout is buildup of uric acid crystals within a joint, which obviously would make it painful if you have crystals developing in a joint. And again, at the great toe is one of the most common places that you're going to see gout manifest itself. So some common impairments we'll see, again, with any type of hypomobility at the foot and ankle, it's going to be restricted motions. If there's swelling, that's going to cause pain as well. At the talocrural joint, plantar flexion is going to be more limited than dorsiflexion, unless the gastroc and soleus group will be shortened, but that's your capsular pattern for the ankle. At the subtalar joint, you'll see progressive limitation of supination until the foot is actually fixed in pronation. So you'll see the arch gradually start to flatten. At the MTP joints or at the great toe, again, limitation of extension here is going to have a pretty significant impact on gait. So terminal stance in preparation for swing phase, it's very hard and painful to push off on that foot. And so you'll see some different compensations and gait deviations there because of that. Some other things that can happen. Another fairly common condition at the great toe is hallux valgus or bunions. And this is when the proximal phalanx is going to shift laterally towards the second toe. So this is where we end up again with this characteristic bunion. Again, I didn't think too much about the great toe until I was working, and then I started getting a lot of referrals from a local podiatrist who was sending his patients to therapy following bunionectomies. So in a couple slides here, we're going to get to the treatment for a bunion like that, and it's typically an arthrodesis, a fusion. But then because of that, we want to make sure that the patient gets back enough motion so that, again, their gait isn't significantly affected. Another condition is hallux rigidus, which is narrowing and eventual obliteration of the first MTP joint space, which is basically significant osteoarthritis of that joint. Again, it's going to affect terminal stance, not allowing the foot to roll over the met heads, not achieving toe off, and it's going to be painful when you weight bear. We can also see dorsal dislocation of the proximal phalanges on the met heads. So what happens here is the fat pad, which normally is under the met heads, it migrates more dorsally, and then the protective cushion is lost. So again, pain with weight bearing, and then eventually too, because the fat pad has shifted, there isn't that cushion there, you can actually see ulceration underneath the foot there as well, underneath the met heads. A few other disorders we can see as we get to the toes are either hammer toes or claw toes. These are usually more of a cosmetic thing. People don't like the way they look, but it can also become a functional thing in that if the hammer toes or the claw toes get in the way of finding properly fitting footwear. If your shoes don't fit right, the toe box is too narrow, it's putting pressure on your toes because they're in one of these positions, that again can make gait and a lot of ADLs much more difficult for the patient. So these can also be surgically repaired as well. So non-operatively, ways we can treat some of these hypomobility conditions. Again, they're going to present with decreased mobility, most likely some muscle weakness and decreased muscular endurance just due to disuse, because again, they won't be wanting to be up and walking around as much because it's painful. We can see some impaired balance and postural control because again, typically our first fight against balance or our first aid to help keep us upright again is that ankle and foot strategy. And so if we're having pain or any limitations with our ankles, our first balance strategy is now not going to work as well for us. We'll almost always see gait deviations. Again, something as little as a tiny little toe hurting can cause pretty significant gait deviations, which will then lead to functional limitations because of painful weight bearing, decreased ambulation, and impaired balance. So if we go into then surgeries to correct any of these, we can see total joint arthroplasties. This would be if there's severe tibiotalar joint deterioration and disabling pain. So this could be due to either osteoarthritis or rheumatoid arthritis. Limitation of the ankle joints bilaterally, or as alternative to an arthrodesis, which would be a fusion. Just a side note, the components of a total ankle arthroplasty don't improve stability of the ankle. So if someone has an unstable ankle, performing a total ankle arthroplasty is not going to fix that problem. Total ankle arthroplasties are rare. I can honestly say I've never seen an actual patient with one. I've seen pictures of them. I know what they look like and how they work, but they don't happen very often. One, the ankle joint tends not to wear down as quickly as the knee or the hip. And then two, as we get a little bit further on and we talk about the arthrodesis for this joint, the ankle fusion, we can talk about why that might be a little bit more commonly seen. So this would be a picture of what a total ankle arthroplasty would look like. You can see too, we still have a little bit here of the dome of the talus, which would be replaced. And then underneath here, the tibia would be replaced, but you lose a lot of that dome there. So again, you will still have some congruency of the joint here, but it's not that same deep socket that used to be there. The implant designs are improving, which we might start to see some increasing popularity of this surgery. But the main goal of a total ankle arthroplasty is going to be to decrease pain and still allow for some mobility at the ankle. The patient will need to have intact ankle ligaments in order for this surgery to be successful. So post-op management, the patient is most likely going to be immobilized for a minimum of 3 to 6 weeks following surgery. They may be non-weight bearing during this time. There's not a lot of guidelines in the literature as far as what are the best rehab protocols for patients following total ankles, and there's a lot of variation in what is being sent out there by the physician. So if you do ever see a patient following a total ankle arthroplasty, do make sure that you have instructions from the physician as to what you should and should not be doing with them during rehab. We can typically begin with some isometrics fairly early on, start to begin some range of motion. If they are not casted, a lot of times they'll be in some sort of immobilizer or boot, which they can take off for exercise. Focus primarily on dorsiflexion and plantar flexion during this time, and then strengthening again of the associated areas. So do lots of like quad, hamstring, hip strengthening as well in preparation for gait down the road. If they are able to be weight bearing at all, they will typically be in an immobilizer. So make sure they're wearing that for any gait activities. So they will probably also need an assistive device initially. So make sure that they are fitted properly for that and using that properly for ambulation. Moving into the moderate and minimum protection phases following the total ankle. Again, range of motion, our goal is to get normal ankle range of motion back by about 6 weeks. We'll begin with open chain exercises and progress to closed chain eventually. We can use tubing to offer resistance. Tubing or TheraBand is usually a little bit easier at the ankle versus using ankle weights because you have to wrap them around the foot for them to work. Again, we'll progress to closed chain. We can start with seated BAPS board. BAPS board it's a brand name. It stands for Biomechanical Ankle Platform System. If you're not familiar with what one looks like, I do have a picture in a little bit and I'll go over that again. But it's just almost like a rocker board that you can put on the floor. It's a circular shape. And then you can have your patient do ankle range of motion exercises on that board. There's different size, like half circle balls that go underneath the board. And so you start small, so it just covers a little bit of range of motion. And as the person progresses, you can put bigger and bigger balls underneath the board, which makes the person go through bigger ranges of motion. We can then, again, we usually start that in seated, and then as the patient gets more weight-bearing capabilities and gets stronger, we can eventually progress them to weight-bearing in standing as well. All right, so we're going to talk about arthrodesis now. This is actually the most common surgery for late-stage arthritis at the ankle. So these are going to be more common than total ankle arthroplasties. This x-ray I included here just to show you the difference of what an arthrodesis is going to look like versus a total ankle arthroplasty. So again, with the arthroplasty, we're resurfacing or replacing both the joint surfaces here. With an ankle fusion or an arthrodesis, we're actually just sort of closing off or clamping down or combining and joining some surfaces together. We're fusing them together with these screws. So an arthrodesis would be indicated if there is severe joint deterioration and disabling pain. So again, that's the same as for a total ankle arthroplasty. And if there's also instability with weight bearing. Again, the total ankle is not going to do anything for someone with instability at the ankle. The arthrodesis will help to increase stability at the ankle. Deformities of the toes, foot, and ankle can be fixed with an arthrodesis. And patients that have high functional demands might do better with an arthrodesis than with a total ankle arthroplasty. This may actually be a salvage procedure also after a failed total ankle arthroplasty. So the surgeries can actually work for each other in that way. What is most common is typically what we call the triple arthrodesis of the ankle. So this is stabilization of the hind foot by fusing it to the midfoot. So it's going to fuse the talocalcaneal, the calcaneocuboid, and the talonavicular joints, which is going to provide some medial and lateral stability. Pronation and supination is going to be lost, but it's also going to allow for continued dorsiflexion and plantar flexion, which is going to be more functional for the patient. You can also fuse the tibiotalar joint as well. This is not as common. When you fuse the tibiotalar joint, you're going to lose pretty much all dorsiflexion and plantar flexion at the ankle. It will be fused in a little bit of a dorsiflexed position because that will be more functional for your patient. The forefoot for this procedure does have to be stable and pain-free because it's going to end up compensating for some of that lack of motion. So this is a picture of a triple arthrodesis. This is what's happening. So again, they're fusing the hind foot, which again was the calcaneus and the talus, to the midfoot, which was the cuneiforms, the cuboid, and the navicular. So the hind foot and the midfoot get fused together. This did not affect the tibiotalar joint. So there's still full dorsiflexion and plantar flexion available here. You are probably going to lose a little bit of inversion and eversion, and you lose supination and pronation at the foot. But again, they will fix it in a neutral position and fuse it in this position. So this is typically going to be the most functional type surgery for your patient with the best functional outcomes. Fusions are also going to take place at the toes to fix hallux rigidus, hallux valgus. Hammer toes, claw toes can also be fixed with arthrodesis or fusions. So again, this would be the bunion or dislocation of the joint. So again, they will put 2 screws in, 1 screw, whatever it takes in order to fuse that joint together. So this is going to be the treatment for hallux rigidus and hallux valgus, which can help to reduce pain. And again, it is going to be fused, or they'll put it in a position with a little bit of extension already at the great toe, which will allow then for some push off during gait.
Hi, it's Kevin.
So as I mentioned, hammer toes and claw toes can also be fixed with an arthrodesis. They will fuse the interphalangeal joints of the toes. It usually happens with the second or the third toe, which helps to correct the deformity and will help to provide relief for ambulation. Also helps, again, with fitting of footwear so that that's more comfortable for your patient. They may be immobilized for 6 to 12 weeks. They may be non-weight bearing for a period of time to allow that fusion to actually heal. And then they'll typically progress then to partial weight bearing. They will typically wear some sort of immobilizer or boot on that foot when they do begin weight bearing. When we are rehabbing someone following any type of arthrodesis procedure at the foot and ankle, we want to make sure that we are maintaining active range of motion to all the adjacent joints and make sure we're maintaining mobility there. And then once they get out of their immobilizer or their boot, we want to make sure that they're choosing proper shoes. We want to make sure they have something with good shock absorption, a decent amount of support, and relief of pressure. They may need to get custom-made orthotics. They may even be able to get away with over-the-counter orthotics, but we do want to make sure that they get shoes that are going to be comfortable. We get asked a lot, what kind of shoes should they wear? Really, the answer is anything that feels good. So make sure they go and they try on a bunch of different shoes and find something that's comfortable for them. We do know that with things like different things going on with the toes and things like that, some shoes are going to be more narrow than others. Like very typically Nike shoes tend to run on the more narrow side. We want to look for something that has a bigger toe box or more area for the toes if there was anything going on with the toes. So sometimes New Balance, Asics to some degree have some shoes that have a wider toe box that might be more comfortable for your patients. All right, so we're going to go over some tendon issues that happen at the foot and ankle. Specifically, we're going to talk a lot about Achilles tendonitis and some things that can happen there. But just like in the hand and wrist, you have a whole bunch of tendons that run down into the foot and the ankle, and any one of them can become irritated with a tendonitis. And so we will treat them like we do any other tendonitis. But let's talk specifically about Achilles tendinopathy right now. So this is typically noted as pain in the midpoint of the Achilles. The person will start to lose some dorsiflexion because it hurts to stretch the Achilles tendon. It will hurt when they contract into plantar flexion because now we're using that tendon, and they will lose some strength of the plantar flexors. We will typically see some increased foot pronation as well and an altered gait pattern. The person will try to avoid painful activities, or we should tell them to avoid painful activities. A heel lift may actually what that does is if we lift that side, that puts that Achilles on a little bit of slack and lets it relax a little bit and should help to reduce their pain. And we can use modalities to help control pain as well. So like I said, any of those tendons that run into the foot can become inflamed and develop a tendonitis. And then plantar fasciitis, that's another fairly common condition that you're going to see in the foot. It's pain along the plantar aspect of the arch, most likely. Oftentimes it'll come down towards the heel as well. So it's usually not up by the met heads or up into the toes. It's through usually the arch back towards the calcaneus as well. It's where the plantar fascia is going to insert on the calcaneus. A heel spur may actually develop there as well, which will show up on x-ray, which obviously if you have a heel spur, an extra bony growth on the calcaneus, that will make weight bearing and gait painful as well. But that can also irritate the plantar fascia. Some other overuse syndromes that come from repetitive trauma, shin splints are one. When I say shin splints, most people usually think of anterior shin splints, and those are definitely the most common. That is an irritation of tibialis anterior. And again, it's usually from some sort of overuse injury, a lot of running, walking, anything like that can start to irritate the tibialis anterior. But you can also have posterior shin splints as well, and that's irritation of posterior tibialis muscle. And that presents usually more on the medial side of the posterior part of the lower leg. Treatment for shin splints is going to typically start with avoidance of the provoking activity. So if it was running or walking or whatever it was, try to get the person to avoid that for a period of time to try to let the shin splints calm down a little bit. We can use modalities to try to reduce pain, stretching, either stretching tibia anterior or posterior, whichever one seems to be most involved, and then a gradual return to activity. We can also do things like, sorry, I skipped ahead here, cross-friction massage, gentle isometrics to the area, maintain range of motion, so doing some ankle range of motion, again in a pain-free range, avoidance of the provoking activity, and we may try some taping as well. So taping has been shown to be fairly successful in helping to alleviate symptoms. And again, once we get the person calmed down, it's trying to make sure that they just make a gradual return to whatever activity it was that they were doing that caused the problem. Continue to stretch. It's important to try to teach them to do a pre and post workout stretch to try to maintain the length, strength, muscle balance relationship there. And then patient education, again, about preventing that return of symptoms. So it's much easier to go out and just do a little bit and not have the symptoms come back than to go out and try to get back to your regular old program. And then all of a sudden you flared the shin splints back up again, or whatever tendinitis it was back up again. And then you have to take several weeks off again just to try to get it to calm down. All right, so let's go back to the Achilles, more severe condition here, but let's talk about an Achilles rupture or an Achilles avulsion. We see it more in adults between the ages of 30 and 50. It's a little bit more common in men than in women. It's usually associated with either a forceful contraction of the plantar flexors or eccentric dorsiflexion control. So either things like landing from a jump or sprinting or slowing down really quickly. There are some more specifics to the actual surgical intervention in your book, but we will talk about some of the treatments. So typically our acute phase in the first 2 weeks, they will most likely be in a CAM boot, which just stands for controlled ankle motion boot. That's all that means. And what it's going to do is it's actually going to place them into plantar flexion. So they're going to be in a maintained plantar flexed position so that we can shorten the Achilles tendon and allow it to heal. They will most likely be partial weight bearing and need to use axillary crutches for a period of time. As we progress through the acute phase into the 2 to 4 week range, the CAM orthosis can be adjusted, but it's still going to restrict all dorsiflexion, so no dorsiflexion at all, and we're going to stay into about 20 degrees of plantar flexion. So that means the foot is plantar flexed at about 20 degrees. The patient should probably progress to weight bearing as tolerated at this point. They will still need to wear their CAM boot whenever they are weight bearing, and they might be able to start to wean off the crutches at this point. In the 4 to 6 week time frame, the person can now actively plantar flex, but they still cannot dorsiflex. So minus 10 degrees, meaning 10 degrees into plantar flexion. And by week 5, usually to neutral, to 0 degrees. They should be full weight bearing if they are wearing their boot. And again, make sure to start to get rid of the crutches by this point. 6 to 8 weeks, again, still wearing the walking boot for weight bearing, and they can now go into a little bit of dorsiflexion. So the boot will allow up to about 10 degrees of dorsiflexion. Might start to be able to wean out of the boot and into shoes, but they will typically suggest the patient wear a heel lift, at least for a period of time, again, to keep the Achilles on a little bit of slack. Again, patients should be full weight bearing by this point. And then 8 weeks and beyond, eventually get them into their regular shoes, no heel lift, hopefully by about 10 weeks or so. There is early weight bearing and mobilization, which follows pretty much the same protocols. It just moves through a little bit faster. So initially following Achilles repair, the person can ambulate with crutches and their boot, which will be, again, fixed in a little bit of plantar flexion or neutral. They will typically progress to full weight bearing by 3 to 6 weeks post-op. So this is the early weight bearing protocol. So they are full weight bearing a little bit sooner than they were following that traditional chart that I just showed you. Their orthosis or their boot needs to be worn for all weight-bearing activities for at least the first 6 to 8 weeks post-op, and then full weight-bearing without their boot, but wearing shoes with a heel lift at about 6 to 8 weeks. So they're back into their shoes again a little bit sooner. As far as range of motion exercises go, they can start pretty much right away, but again, dorsiflexion is going to be limited because if you're going into dorsiflexion, you're stretching the Achilles tendon, and we don't want to stretch it yet. We need to let it heal. So during the first 4 to 6 weeks, they can do inversion and eversion. They can do some plantar flexion. By 6 to 8 weeks, dorsiflexion starts to return, or they can start moving into some dorsiflexion up to about 10 degrees. And then during that first 6 weeks, everything should be performed supine or seated. Again, open chain exercises for your range of motion. During the maximum protection phase, the acute phase following an Achilles repair, we want to make sure that they're ambulating independently. So again, they might need crutches, the walking boot, maintain range of motion of all non-immobilized joints, so the knee, the hip, the other side, prevent reflex inhibition. So we can do some submaximal isometrics of dorsiflexion, inversion, and eversion while they're in the boot. They cannot do isometrics for plantar flexion. So these are the two big things that are limited during or following an Achilles repair. They cannot actively dorsiflex, so we have to limit dorsiflexion range of motion because we don't want to stretch the Achilles tendon. They also cannot actively plantar flex because we don't want them contracting and pulling on the calcaneus. So you can't do isometrics into plantar flexion. You can do them in the other directions and work those muscles. We want to prevent joint stiffness and tissue adhesions. They can take off their boot and do some range of motion. Again, everything but dorsiflexion initially. Begin to restore balance. So making sure that, you can start with double leg balance things like the Romberg stance, reaching activities and things until we can eventually progress them to single leg stance, and maintain cardiopulmonary fitness. So they might be able to eventually get to the bike, but if they're not initially, do things like the arm bike to work on their cardiovascular fitness until they can get onto probably the recumbent bike or the upright bike. Into the moderate protection phase, by this point, we should be aiming for full weight bearing with the walking boot or their cam orthosis, getting to about 0 degrees of dorsiflexion. Again, about 6 to 8 weeks post-op, we should be able to start getting into regular shoes with a heel lift. Remember, we're going to have that there too. We want to begin to increase range of motion of the operated ankle, so we can do some mobs. We can start stretching into dorsiflexion. It is going to be tight. Dorsiflexion is for sure going to be limited. We had to not dorsiflex for a period of time, so that Achilles is going to be shortened. It was purposefully shortened so that it would heal better, but now because of that, it is going to be difficult to get some of that dorsiflexion back. So doing things like rocker board, BAPS board, standing on a wedge, taking a wedge and putting it next to something that the patient can hold on to and have them stand with their heel down low, foot up towards the higher part to stretch them into some dorsiflexion there. We can usually do some strengthening and endurance training now. Again, begin with open chain, low load, high reps, so more endurance type activities initially, and then progress to closed chain. Working on balance, continue to do that. Reestablish a symmetrical gait pattern. Things are going to be off. They've been wearing a big clunky boot for a period of time. So once we can start getting them into shoes, we want to try to start to normalize that gait pattern again and continue to work on their cardiopulmonary fitness as well. So this is a BAPS board that I was talking about. So it's this circular board, and the underside looks exactly like this. One side is for left, one side is for right. So then what you would do is these are the different size balls that can go underneath. So you would take the small one off. It usually goes in here in the center to start, and then you put that side down. So this would be on the underside, and then the person will actually rock the board. So we can have them do like dorsiflexion and plantar flexion, inversion and eversion, and then we can have them do circles in each direction. Typically, we will start with the patient seated and then eventually progress to them standing. So then finally in the minimum protection phase or the chronic phase of healing, return to function phase, this is usually going to begin somewhere around 12 to 16 weeks post-op. We want to get them back to their pre-injury status. So whatever work-related demands, functional demands, recreational, sporting demands they have, we want to make sure that they're going to be safe with those. If they don't have full dorsiflexion yet, which I would say minimum 10 to 15 degrees would be needed, we want to make sure that we're getting that back, and then continue strength and endurance activities. So we can start doing some eccentric loading of the calf at this point. So sometimes we'll start with unilateral heel lowering. So what we'll do is have a person stand on a step. You can use one of the like steps in the clinic, go up on both legs, so double leg calf raises, and then pick up the good leg. So now they're just standing on the injured leg, and then they slowly lower that down. It is typically, again, easier to start with some eccentric strengthening. Eventually, we do want to get back to plyometrics. If you can do that in the pool, that takes a little bit of that impact out, so that would be a good idea. And then we can usually begin treadmill walking on an incline. So again, walking on an incline is going to force that foot into dorsiflexion. So 12 to 16 weeks, you can start that. That is a good activity to do if your patient is lacking any dorsiflexion still. Usually at least 4 to 6 months before we're talking about returning to sport. So your patient has to be able to ambulate pain-free. They have to be able to run, and they have to pass the functional hop test with 90% of the contralateral limb. So what that means, if you're not familiar with that, is we will have them typically do a single leg hop, and we'll measure how far they can hop on the good leg, and then we'll have them hop on the bad leg and make sure they can get about 90% of that same distance. If they can, then that usually means they're ready to return to sporting activities. All right, so ligaments of the ankle. This is showing the lateral side of the ankle. This is the fibula coming down here. So we have 3 major ligaments that support the lateral side of the ankle. Your anterior talofibular ligament, or ATF ligament, your calcaneal fibular ligament, or CF ligament, and your posterior talofibular ligament, or PTF. Whenever you have a lateral ankle sprain, the ligaments tend to get stretched or injured in a predictable order, and it goes this way. So it's going to start, the ATF is your most commonly injured ligament at the ankle, followed by the CF, and then back to your PTF as well. This is the medial aspect of the ankle. This is collectively known as your deltoid ligament, and that is your major support for the medial portion of the ankle. You can absolutely sprain the medial portion of the ankle, just more likely to sprain the lateral portion of the ankle. So the ligaments can be stressed or torn. Again, typically it's an inversion type stress, which can damage the ATF, CF, or PTF ligaments. Again, ATF is going to be the major ligament that's involved with any inversion stress. To get the posterior talofibular ligament, it has to be a massive inversion stress. It's the strongest ligament. It typically remains intact, so it has to be something pretty major to involve that ligament as well. And then also depending on the severity of the injury, the joint capsule may be involved, because most of those ligaments do have some contact with the joint capsule. So looking at the degrees of an ankle sprain, first, second, third degree, a first degree ankle sprain is going to be some stretching or mild tearing of the ligament, little to no functional loss. You can still function, you can still bear some weight. It is going to hurt. I'm not saying it's not painful, but you can still function. So there is some pain, some swelling, some joint stiffness, but you can typically continue on with activity. A second degree ankle sprain is going to be more severe tearing of the ligaments, more instability then of the joint as well, moderate to severe pain. Weight bearing is going to be painful. Again, one of the biggest characteristics between a first and a second degree sprain is that a second degree is going to require stoppage of activity. It hurts enough that you cannot continue to do whatever it was that you were doing. There will be more significant swelling and stiffness associated with this as well. A third-degree ankle sprain is going to be a total or near total rupture of the ligament. So loss of motion initially, but then the ankle is actually going to be more unstable. Ligaments typically do not heal themselves very well, and so because we've now completely torn that ligament, that ankle is now going to be more unstable and more prone to continued ankle sprains. Again, severe pain initially followed by no pain because that ligament is completely torn. You can stress test or try to move the ankle into inversion. There's nothing to stop it at this point. And there will be severe swelling as well. So here are some pretty nice, big, swollen ankles. A lot of times, again, you'll see this big ballooning over the lateral side. It can even travel over to the medial side as well if the capsule is involved. And again, there just isn't a lot of room at the ankle, so the swelling will often overtake the whole ankle. As it progresses, it starts to turn a pretty purple color. This is from the torn ligaments. It will actually start to pull down towards the bottom of the heel. That's just because of gravity. And you can even see some down by the toes as well. So following a tissue injury, ligamentous injury, ankle sprain, you'll see some pain. You'll see muscle inhibition or muscle guarding at the ankle, instability or excessive motion at the ankle eventually, proprioceptive issues. Again, remember our ankle strategy is our first balance strategy. And so if those ligaments are disrupted, we've sort of impaired now our first balance strategy. The person will present with decreased weight bearing, decreased range of motion. They may need an assistive device to get around for a period of time. And again, they are probably more likely to have this injury again because of the instability that is now present at the ankle. During the maximum protection phase following an ankle sprain, again, this is non-operative management, so just following your ankle sprain, RICE, compression, RICE, rest, elevation, and ice application. Try to immobilize in a neutral position or maybe even a little bit of dorsiflexion. The person is going to want to tend to plantar flex a little bit. That is going to be more of that open pack position for the ankle. It's going to be a position of comfort, but we do want to make sure that we're not going to develop a lot of stiffness there, so try to get them into a little bit of dorsiflexion if at all possible. That also takes some of the strain off of that ligament. We can use modalities for edema and pain control. Ice, again, every couple hours. Teach the patient to walk with an assistive device if needed. They can begin some isometric exercises as long as they're tolerated, so submaximal, all four planes, and again, continue with the price. In the subacute or controlled motion phase, they might need an orthosis, continue with gait training. They should hopefully be weaned off of any assistive device by this point. Continue to progress or advance the exercises that they were given in the acute phase, avoiding end range inversion. We don't want to stress those ligaments that were already strained. So continue to do range of motion in all directions, foot and toe exercises, stretch gastroc and soleus. Again, the person is going to want to tend to plantar flex to some degree. And so the gastroc and soleus do usually become tight. They also become tight because of some muscle inhibition as well. So again, as they are more and more able to weight bear more and more weight, add the bike, balance training, BAPS board, progress from open to more closed chain activities because most lower extremity function is happening in the closed chain. And then finally, as we return to function, keep adding more resistance, TheraBand weights, progress to more movement patterns, cross-stepping, side-stepping, forward, backward walking. You can add some agility exercises in, balance, progress all your balance activities. You can do balance activities then on the BAPS board or BOSU to make them more challenging. Again, and because most functional things in the lower extremity are closed chain, continue to work on closed chain activities. Surgical repair of ankle ligaments. If the person has continued ankle instability and they continue to sprain their ankle all the time and it's painful, they might elect to have them surgically repaired. So this is for complete ligament tears or gross instability of the ankle joint. They can do a direct repair or reconstruction of the ankle ligaments. Post-op, they are typically going to be immobilized for 2 to 6 weeks in a cast, which will then be replaced by a cam boot. They can be instructed in range of motion. Inversion and eversion are going to be limited initially because, again, it's the ligaments that are going to protect against inversion, so we're going to not do that motion for a period of time. And then by 6 to 12 weeks, we should be able to discharge the immobilizer. Their weight bearing will most likely be limited following surgery, so follow whatever guidelines are given to you by the physician, but they may need an assistive device for a period of time, so make sure they're using it safely, gait training properly. So in that maximum protection phase, usually, again, 4 to 6 weeks, we want to prevent reflex inhibition of the immobilized muscle groups, so we can do submaximal isometrics, again, in neutral, so we usually keep them in if they're casted or in their immobilizer. We want to prevent stiffness. So again, as much as we can range, if they're casted, you can't do a lot. But we're going to try to do as much active range of motion as we can whenever that is removed. In dorsiflexion and plantar flexion, inversion and eversion, again, are going to be a little limited in the beginning. Make sure they're moving their toes. Again, we want to maximize independent mobility. So if they need a device, make sure they're gait trained with it. And then maintain the strength of all the non-immobilized muscle groups. So continue to do lower extremity strengthening, just not of the ankle right away. As we move into the moderate and minimum protection phases, we'll wean from the immobilizer and off of the assistive devices. We are trying to restore full pain-free range of motion. Minimum protection is usually going to begin somewhere around 8 to 12 weeks post-op. And by this return to function phase, we are hoping to have full muscle strength and endurance back in the lower leg and ankle, pain-free gait and running, improving neuromuscular control, balance, dynamic stability, agility, so all sorts of balance and proprioceptive type exercises, agility drills like the ladder, and then work from a stable to an unstable surface, double leg to single leg at about 6 weeks. Again, pain-free, symmetrical weight bearing during gait, and then a gradual return to all functional activities. So depending on what that person needs to be able to do. All right, that's it for the ankle, guys. Thanks.